is CoronaVac globally. And this is super important to remark because many of the low and middle income countries globally have received this vaccine. So that's something that we have to remember always. And this is Hong Kong. How are you vaccinating people? So mostly in the young adults, Pfizer's predominates. Then it's pretty much the same. The elderly population and below 11 years old, there's a predominance of CoronaVac. The same happened for the 6 months to 3 years old group. And of course, there's still work to do, but probably you are the only country that is vaccinating so much in this age group. We approved Pfizer's and vaccine and CoronaVac for kids between 6 months to 3 years, but the use of that of the vaccines in that group so far it's been anecdotal. So I don't have any VE data to show you for that age group. But what we can start thinking about this is, from this interventional trial. So it's still ongoing, but I'm not sure if I'm the one doing the noise. I hope not. But you can see here then in this trial, there's an inclusion of 200 kids between 6 months to 3 years from South Africa. And there are some initial data showing, here are the numbers. So they expect to recruit 200 subjects. They reached that number already. And then you can see here some initial reports about immunogenicity. And as you can see here, before vaccination, after vaccination, always the same group. Then in clear color, you have placebo, and then the blue one, I think it's blue. You have CoronaVac. So you see that after the dose of 1 month after completing the primary series, you have 100% conversion rate, and the placebo is still the same. And when you separate that among those that were seropositive or seronegative before vaccination, you see that the effect is more clear among those that were seronegative, but still you can see an increase among those that had a history of some kind of exposure to the virus before the study. Then you can see here that as expected in other, based on other experience, the adverse events in general are pretty low. They didn't see any severe adverse event, and then there are no differences between placebo or exposed groups in terms of reactogenicity or adverse events. This is the same adverse reaction when you go into different. Sorry, there's some kind of echo, but it's okay. But in summary, what I'm trying to show you here is that CoronaVac in this age group seems to be able to increase antibodies, and also it's as well tolerated as in other age groups. And so finally, this is another update. I think it's important for your current situation. This is a study that's from Hong Kong and is basically showing you the effect of the population level, right? Real world effectiveness of different vaccination schedules: 2 coronas plus corona, 2 coronas plus Pfizer's, 2 Pfizer's plus corona, and 3 Pfizer's. And you can see that the effectiveness against symptomatic infection is very similar and comparable in the adult population. And that's something that we also see in our mixed and matched studies. So it seems that from different parts of the world, regimens that have a mix of mRNAs and inactivated vaccines are performing super good against not just against severe disease, but also against infection. So finally, this is another study from different groups, but led by a doctor from Hong Kong as well, that compares how well tolerated vaccines are. In this case, seems that based on this analysis, Coronavac had a kind of better profile in terms of reactogenicity than Pfizer's. That's something that it's been shown before. So, so just to finish I think I'm still on time, but I have, these three conclusions. We know that Coronavac, an inactivated vaccine, remains highly effective against Omicron sublineages, and that's important, especially for severe disease. We know that Coronavac VE data in children and adolescents is similar, if not better, than the performance observed in the adult population. And we also know that safety and reactogenicity is high across the whole age spectrum. We're working now in trying to model the importance of the vaccination coverage. And it seems that when you vaccinate people a lot and very rapidly, you can achieve results that are very similar to those countries that remain closed in terms of the severity of the restricted medicines interventions. So it seems that vaccination is going to continue to be super important, and I encourage you to continue doing the great work that you are doing, and tell us how it is going in the 6 months to 3 years group as soon as you have some data. So thank you, and open to questions now or later.
Yeah, thank you, Dr. Raffo. And I'll share my screen and talk about some recent data in Hong Kong. So this is the recent data in Hong Kong, and up to today we got new confirmed COVID cases, 4,600. This is the data for today. And up to now in Hong Kong, we got 8 children, and unfortunately died of the COVID. And during the 5th wave in Hong Kong, the age ranged from 11 months to 9 years of age. And this is the information to the audience, that also to the public, that all of them, in fact, unvaccinated or received only 1 dose of the COVID-19 vaccine. So 8 children in Hong Kong died during the 5th wave of the Omicron outbreak. And also we got cases of the MISC, and this is the Hong Kong diagnostic criteria for the MISC, and age less than 18 years old with evidence of the SARS-CoV-2 infections, and with 2 or more system involvement, including the gastrointestinal, hepatopancreatic, neurological, respiratory, and skin, and also cardiovascular and renal involvement, and also evidence of raised inflammatory markers, and the diagnosis cannot be explained by any alternative diagnosis. And up till now, around 70 cases of MISC diagnosed in Hong Kong already. So this is the vaccination figures in Hong Kong. And despite the launch of the vaccination of the children from 6 months to 3 years from the 1st of August, now the figures is still quite disappointing. Only 17.5% being vaccinated in this age group. So this is for the overseas speakers' information. So I'm going to introduce the next speaker, Professor David Weber, the Professor of Medicine, Pediatrics and Epidemiology, the Associate Chief Medical Officer, and also Medical Director, the Department of Infection and Prevention, UNC Medical Center, the United States. He's going to talk about the vaccine efficacy, effectiveness, and safety of COVID-19 mRNA vaccines in children. So, Professor Weber, please.
Thank you very much. It's a great pleasure to be talking to you. I'm only sorry I'm not there in person. And let me share my screen. Give me just a second. Good. I hope you can all see my screen. I'm going to talk about vaccine efficacy, effectiveness, and safety of mRNA vaccines in children. Efficacy is defined as the data we get from a randomized controlled trial, effectiveness is considered real world data. With that, here's some important safety information about the mRNA BNT 162b2 vaccine. Of course, any vaccine should not be administered to someone with known hypersensitivity to the vaccine itself or an active substance there. And in addition, the vaccine can cause rare cases of myocarditis. And because of the possibility of hypersensitivity, you should always have resuscitation equipment available. The efficacy, safety, immunogenicity has not been assessed in immunocompromised individuals, although it is specifically recommended for those. With that, let me go on with my talk. So here is the current COVID-19 epidemiology in Hong Kong. You can see, and you've already seen some excellent data just presented. You can see here that the predominant variant of Omicron is now the BA.4/5 variant, with just a very small numbers of BA.2 variants, Omicron variants being present. And you can see that in the numbers on the left there. Where we actually have the numbers there, and you can see BA.4/5 is now over 90% of the variants in Hong Kong. Daily hospitalization rates are 2.5 per 100,000, and death rates 135 per 100,000 population. Approximately 1 to 2% of daily cases have previous infection recorded, demonstrating that natural immunity is certainly not perfect, and imported cases are a small number of the total cases each day, constituting somewhere between 3 and 5%. Now, in terms of the severity of BA.2 in unvaccinated children, it really was not mild in Hong Kong during the fifth wave. This study was a population-based case control study of hospitalizations in all public hospitals and compared the severe outcomes of Omicron BA.2 dominated fifth wave to influenza and parainfluenza. And you can see here that there are about 1,000 cases of Omicron and roughly 45,000 cases of influenza and parainfluenza. This was in children 0 to 11 years of age. And they looked at fatalities, admissions to pediatric intensive care units, and neurology and respiratory complications. Well, you can see here that neurologic complications, which were mostly seizures, occurred in about 15% of the hospitalizations, with more severe disease, encephalitis, encephalopathy in about 5 cases. Case fatality rate was 0.2%, which is fortunately of the hospitalizations low. But I will point out it was approximately 5 times higher than compared to influenza, demonstrating that COVID-19 is a more severe disease than the common respiratory viruses. In terms of PICU admissions, the rate was twice as high as influenza there, and the rate of croup was also twice as high. Again, all demonstrating that COVID-19 is a more severe disease than common respiratory infections. Well, let's go ahead and talk about the impact on children. I want to cover one important finding, which is the multisystem inflammatory syndrome in children, MISC. It's an uncommon but severe inflammatory disorder that occurs after recent SARS-CoV-2 infection. Most common signs and symptoms, in addition to fever, are abdominal pain, vomiting, rash, diarrhea, and conjunctivitis. Involvement, though, of at least 4 organ systems occurs in 90%. Importantly, hypotension, low blood pressure, or even worse, shock, occurs in 50 and 35%. About 60% get admitted to an intensive care unit, 30% of cardiac dysfunction. Myocarditis and pericardial effusions can occur in 15 to 25%. And fortunately, most patients, even though they have these severe symptoms, don't die. But approximately 1.4% will die. Turning now to the proportion of children and adolescents with persistent symptoms after SARS-CoV-2, so-called long COVID, although that's been well described in adults, It certainly occurs in children as well, as you can see here. You can see here on studies without controls at the bottom, it's occurring in anywheres up to as many as 60%. In part, it depends how closely we look for it. And when you do look at studies with controls, you will find a number of studies. 3 are listed here by Drs. Miller, Molteni, and Stephenson. You can see here that when you have controls with other diseases, such as influenza, you will find persistent symptoms more commonly with COVID. So this is certainly of concern. And at my hospital, we actually have a long COVID clinic, and I'm in a relatively small town of about 50,000. We have seen about 1,500 patients admitted to our long COVID clinic so far. In addition to all the diseases, children are potentially important drivers of SARS-CoV-2 spread in the general population for several reasons. One, they have higher viral loads, as are seen here. So this is one of the reasons for vaccinating children is so important, because it actually protects more vulnerable adults, older adults who are more prone to have severe outcomes, immunocompromised adults as well. And you can see here they looked at children at different ages, less than 5 to 17, 18 to 65, and they looked at their viral loads. And as you can see here, looking at RT-PCR as a measure, you can see here that the children had lower levels of CT, which equates to higher virus. So children certainly excrete more virus. That's similar to other viral respiratory illnesses. In addition to excreting more virus, particularly younger children are less able to control secretions, that is, use tissues, and so they are much more likely to spread disease to adults. And certainly this is an important reason for, as I said, for immunizing children. Well, turning now to a focus on vaccines as a major mitigation strategy, I want to show you what I find a very useful model. It's called the Emmentaler-Cheese model of pandemic defense. And I think it's a good way of approaching COVID mitigation, and in fact, all medical errors as well. And what this shows is you have to line up the holes in the cheese to get infection, which means not physical distancing by at least 2 meters, not performing hand hygiene, not cleaning surfaces there, touching nose and mouth when you have contaminated hands. Those are personal preventive interventions. Shared interventions include use of vaccines, quarantine, and close contacts, people infectious or who have been exposed. Certainly mass lockdowns as well can help prevent transmission. But I also like this because it does talk about factors undermining prevention, certainly things like pandemic fatigue, vaccine hesitancy, which is a particular problem in the United States. The United States ranks less than 50th in the world of vaccine coverage, misinformation, and things that we can all do to help with prevention as physicians and public health people, education, obtaining public trust, harm reduction, and effective risk communication there. Well, the rationale for administering COVID vaccines to children is many. First of all, the vaccine, there's a substantial COVID incidence and burden in children. We've already talked about that, myself and the excellent previous speaker. Certainly causes hospitalization rates and COVID-associated mortality. In fact, in the United States right now, COVID is the leading infectious cause of death among children. We mentioned the importance on common, but still a substantial morbidity of multi-inflammatory syndrome in children. We talked about post-COVID conditions. Certainly, if children become ill or we have lockdowns because of people becoming ill, they miss school, which is detrimental to children there. So all of those are reasons for administering vaccine to children. Well, let me now turn and talk about mRNA vaccines in general and the BNT162b2 vaccine specifically. The way these vaccines are made is you cut a piece of the mRNA out of the virus. In this case, it's the spike protein. You coat it with a lipid nanoparticles. Because of the lipid nanoparticles, it gets absorbed into the cell. It's initially treated as a natural mRNA in the body, and the cell's own ribosome processing will make coronavirus spike proteins. Since this only contains the spike protein, it is not infectious and there's no way to actually transmit COVID-19. And those spike proteins are then excreted outside the cell. They're presented to the macrophages and other immune-mediating B cells as well. And you get an immune response leading to substantial levels of antibody, particularly neutralizing antibody. You also get a T cell response. With that, I'm now going to turn to talk to trials, and these are efficacy studies. So this was a phase 3 trial, multi-center randomized 1-to-1 placebo-controlled, observer-blinded, a classical trial of more than 2,000 people older than 12. It did include people healthier with stable pre-existing disease, but who were not immunocompromised there. The primary efficacy endpoints were confirmed COVID-19 at last 7 days after dose 2 in individuals greater than 12, and they looked at people both with and without prior SARS-CoV-2 infection. They also did a very careful look both for solicited and unsolicited severe adverse reactions. Well, what did they find? These are individuals without evidence of infection prior to dose 2, and they found the efficacy, vaccine efficacy was 100% with good confidence intervals there. And again, those were people without evidence of infection. Now, when we add in people who had prior evidence of infection, again, the vaccine efficacy is 100%. And vaccines in people who've already had natural disease do boost their immunity. They get higher levels of neutralizing antibody and therefore more durability for their response as well. So again, excellent response and true efficacy trial. Well, what about the side effects? And here we're looking at 12 to 15-year-olds and 16 to 25-year-olds. The most common side effects are pain at the injection site. Other problems that we'll see in much, much smaller numbers are redness and swelling. You can see that the risks are approximately a little bit lower after dose 2 than after dose 1. But I do want to point out to you that almost all of the side effects are mild to moderate. You're not seeing any severe or grade 4 side effects. So this is similar to other vaccines that we use that are moderately immunogenic in children, such as HPV vaccine or in adults, zoster vaccine. So it's very similar to others. Now, if you look at more systemic events, again, you'll see that mild fatigue and headache, some muscle pain can all occur, as well as low-grade fevers. But again, I want to point out to you that you don't see, or you see in tiny numbers, severe problems, and you don't see any grade 4 toxicities. So very, very small numbers of individuals, less than 0.5% really, withdraw due to adverse events in this trial, less than 1 in 200, and the side effects, similar to many other vaccines, mild to moderate. Well, let's turn now to the efficacy and safety endpoints. The study did meet its vaccine efficacy endpoint, 100% for individuals without evidence of infection and 100% if they did. Adverse events were usually mild to moderate and included injection site pain, particularly few severe adverse events and no deaths reported, and has a very favorable risk-benefit ratio, as we've already just stated. Well, let's turn now to the 5 to 11-year-olds. This is phase 2-3 trials. Again, a multi-center randomized placebo-controlled trial, again, over 2,000 people and healthy with no prior existing disease. And again, a confirmed infection as well as safety endpoints there. Here they're looking at immunobridging success for the 5 to 11 years old at a 10 microgram level. 2-dose series was highly protective against 5 to 11-year-olds when the Delta variant was predominant. And you can see here the vaccine effectiveness is over 90%, and it doesn't change whether someone's had previous COVID or not. And again, adverse events are mild to moderate. They tend to be very short-lived, and again, no severe events were reported. And again, only a very small number, meaning 1 in 1,000 individuals withdrew from the study because of adverse events. Well, now we're going to turn to the trials of 6 months to less than 5-year-olds here. And again, this is an immunobridging study, 2-to-1 randomization, meaning twice as many people got vaccine, about 3,000 compared to placebo, which was about 1,500 there. And although not required for EUA approval, emergency use authorizations, valence was conducted, permitting evaluation of vaccine efficacy. Well, the first thing you see is that you get a robust boost against actually wild type as well as Omicron here. And you can see here against Omicron, you can see this enormous 36-fold increase in titers. It is true that the vaccine is a little less effective against some of the Omicron variants compared to the parental variants, but nevertheless, you can see an enormous increase in neutralizing and antibody titers, and the vaccine is well tolerated. So excellent data on efficacy and safety in older individuals, excellent immunobridging data on younger individuals. And when we do look at, again, people, a third dose here, we're going to turn here with a third dose, which gives you an enormous boost of against Omicron here. So a third dose of a vaccine, very effective for increasing geometric mean titers by many-fold. And again, with and without people who have had a prior dose there. So a third vaccine giving you excellent boosting against all different lineages of SARS-CoV-2, including Omicron, importantly. What about the real-world effectiveness of these vaccines as opposed to trials? This was a nice study by Dr. Olson, published in the New England Journal of Medicine. Use what is now a standard method, which is a case control test negative design. Assess vaccine effectiveness and hospitalizations, admission to ICUs and other mechanisms, other interventions such as mechanical ventilation. Results: 445 cases, 700 controls, 17 cases and 280 controls had been fully vaccinated. And you can see here of the cases, 40% admitted to the ICU, 29% required life support. The overall effectiveness of the vaccine against hospitalization for COVID-19 was, and this is in adolescents, by the way, 94%, and 94% against syndrome negative controls, 98% effective against ICU admission, 98% effective in needing the receipt of life support, and all 7 deaths occurred in patients who were unvaccinated. So again, an enormously successful vaccine in preventing, in the real world situation, and preventing severe outcomes with COVID in adolescents. The vaccine also has other advantages. Here was a nice study from France looking at the MIS-C syndrome, which I already mentioned. This is an inflammatory syndrome not directly caused by the virus per se, but by the inflammatory response to the SARS-CoV-2 virus. And what they showed is if people had received the vaccine, the appropriate number of doses, then they had about a 90% reduction in risk of getting the MIS-C syndrome if they did develop COVID. So as we saw on the previous slide, the vaccine is tremendously effective in preventing severe outcomes, such as hospitalization, deaths, and now we have data that the vaccine similarly is highly effective in preventing outcomes such as the MIS-C syndrome. Now, post-COVID conditions are also less likely to occur after vaccine breakthrough, and we did show you the slide about the risks of long COVID symptoms. Well, most studies on post-COVID conditions occurring after vaccine are focused on adults. 2 have included adolescents, which are listed here. Persons who were previously vaccinated were less likely to have symptoms between 12 and 20 weeks after infection compared with persons who are unvaccinated, odds ratio of 0.22, meaning the vaccine is about 80% effective in preventing long COVID. And the second study, persons who were previously vaccinated had a lower occurrence of post-COVID conditions after infection than those who were unvaccinated. So again, another effect of the vaccine, excellent activities on preventing disease. Well, let's talk about the risk of myocarditis, which is certainly a concern after mRNA vaccines. And one very carefully set of studies looking at young male athletes, they found that COVID led to cardiac involvement in just about 1% of individuals. On the other hand, when you look at myocarditis after mRNA vaccines in one study, the highest incidence was in young males, but it was about 10 per 100,000 cases. So about 1 per 10,000 people compared to about 1 per 100 people getting myocarditis. So in the risk-benefit ratio, there is a much higher risk for getting myocarditis in this set of studies after natural COVID than after the vaccine. And we also often hear about the risks, but we don't hear with the vaccine, we don't hear about the risks after COVID. Here is some studies from Israel and the UK, risk of myocarditis after infection compared to after vaccination here. And certainly we do with these set of studies did show a somewhat a smaller, higher risk of myocarditis, but they found a similar high risk for myocarditis after natural infection. So the mRNA vaccines are, depending on the study, either similar or much lower risk after with vaccine than after natural infection. And we certainly do see a number of myocarditis for a whole variety of respiratory viruses. This is not unique to SARS-CoV-2, but many others such as influenza, adenovirus, enteroviruses can all cause myocarditis in individuals, and in all cases, the risk is higher in young males than in other age groups. So worldwide, COVID-19 is now endemic. It's obviously the pandemic is almost 3 years old. This is something worldwide we'll have to learn to live with. Vaccines are a major prevention mechanism for preventing worldwide SARS-CoV-2. In areas where it is more endemic and more frequent than in China. Masking can certainly be practiced for high-risk individuals, in addition, older individuals and immune-compromised individuals. But worldwide, these cases of SARS-CoV-2 will be with us, and SARS-CoV-2 will now join the 4 already endemic coronaviruses. So it's not that we don't have other endemic coronaviruses. Well, SARS-CoV-2, COVID-19 is generally a more mild disease in children. It does pose a substantial risk for hospitalizations and deaths. And right now in the United States, for the last 2 years, unfortunately, SARS-CoV-2 in adults is the third leading cause of death after cardiac disease and cancer. And in children, it has been and remains the most common cause of death from an infectious disease in children. In addition, children can develop both the MIS-C syndrome and, if infected, can develop long COVID. Vaccine is the best method for preventing COVID-19. It does reduce the risk for the MIS-C syndrome. It does reduce the risk for developing long COVID in children. mRNA vaccines, as I've already shown you, have been demonstrated to be efficacious as well as effective and safe in preventing infection. And as with many other vaccines, such as varicella chickenpox vaccine, they're even better, and influenza vaccine for that matter. They're even better at preventing severe outcomes, hospitalizations and deaths in children and adults than they are preventing infection. And the risk of myocarditis is substantially higher from natural COVID-19 infection than from vaccination. With that, I'm going to stop. And of course, both now and during our panel discussion, I'm happy to answer any additional questions. And I'm going to stop sharing my screen and turn it back over to our moderators. Thank you very much for this opportunity to present this important information to you.
Yeah, thank you, Professor Weber, and thank you, Dr. Raffel, again. And so now we start our discussion sections. And Jenny, you may please read the question from the chat, and we can ask the question to our speakers.
Okay, so I'm reading from the chat now. We have one question for Professor Weber. And the question is, can you kindly comment on any association between the mRNA vaccine with Guillain-Barré syndrome in all age groups? And if yes, what is the current rate with the mRNA vaccination?
So certainly we have seen occasional cases of Guillain-Barré reported after the mRNA vaccine. But at least the data in the United States suggests that it's not higher than the natural rate of Guillain-Barré that occurs in the population. This is different than influenza vaccines, which do have a small, very small, but statistical increase in Guillain-Barré. But that has not been the case with the mRNA vaccines for Guillain-Barré. It has occurred, but compared to the underlying rate of Guillain-Barré and that we see in the population in the United States, it is not different.
You know, for Sinovac vaccine, actually history of Guillain-Barré syndrome has been regarded as a contraindication to receive Sinovac vaccine. But that's not the case for mRNA vaccine, right?
That is correct. It is not the case for mRNA vaccines.
Okay, thanks. That's very good to know, because we have a lot of people asking about this as well. So it's a good thing to be able to reassure the parents and families. Okay, the second question is for all speakers. Is there any real-world data on the effectiveness of mRNA vaccines in prevention of infection and severe outcomes in the age group of 6 months and less than 5 years?
So what type of outcomes? I didn't quite catch. Just outcomes in general, or a specific outcome?
Prevention of infection and severe outcomes.
Severe outcome.
Yes, and the answer is yes. The vaccine has been shown in the United States, the mRNA vaccines, to help prevent severe outcomes in the 6 months to 5 years of age. Again, particularly things, hospitalization and deaths. I will say, while we're talking about young children, there are studies in the United States suggesting, in the world, that a pregnant woman who's been immunized with an mRNA vaccine, we don't immunize children under 6 months of age, as you just mentioned, but there were 2 studies. One showed that if a child born to a woman who's been immunized, it's 0 to 6 months of age, they have about a 50 to 60% reduced risk of hospitalization if they get COVID, that young infant. And the same thing, and then a second study showed they have a reduced risk of death. And this is not too dissimilar from other vaccines, particularly pertussis vaccine, for which we immunize pregnant women, and it's shown to be protective in the young children who are not able to be immunized yet. So another benefit of COVID vaccines is transplacental antibody transmission to the fetus, with some protection even in the first 6 months of life as well.
And Professor Weber, I just want to ask you, and I see from your slide regarding the data on the vaccine and myocarditis, it seems that the girls, the incidence seems to be more. Is it true? Yeah. From the observation in your data?
Yeah, yes, there are small differences between girls and boys that are statistically present, but are not really different from a true clinical standpoint. They're very close, but that is a correct statement.
I just want to show you this paper actually performed in Hong Kong, and we published in the Clinical Infectious Disease. We in Hong Kong, we have a working group regarding the incidence of the myocarditis following the BioNTech vaccine. and we found that the association was actually more in male, and following the second dose of the BioNTech vaccine, it is more in those 12 to 17 years of age, and the boys actually more than the girls, and so this is actually our findings in Hong Kong. Just for your comments. Yeah.
Yeah, well, I would say that, yes, in general, most studies have shown that myocarditis is more common in men than women. And I should say that's true after natural infection, as well as you're pointing out, true after vaccine. So it's more common in males than females in general in most studies. And it's also more common, as you point out, in younger men than in older men, most common in adolescent aged males. So those are correct. And you also point out that it occurs relatively shortly after receiving the vaccine. All of those have been studied, and this is a wonderful paper, and a number of other studies corroborate that this is true.
Yeah. And there's a question from the audience that do we have the real world data of the chance of myocarditis from the mRNA vaccine from 6 months to 5 years of age? And if yes, what is the rate of the myocarditis?
Yeah, I have to admit, I have not seen a paper that looks at that very young age group after vaccine that I can quote you at the moment. As we've said in your paper and other papers, it does appear that myocarditis, both after natural disease and after vaccine, is more common in older adolescents than in younger ones in general. But I don't have a paper that I can remember with the youngest age groups.
Okay, thank you. So the next question will be, would inactivated vaccine available in the States, and which would improve the vaccine hesitancy?
So dealing with vaccine hesitancy in the United States has been very difficult, I have to admit, particularly with COVID vaccines. It's gotten wrapped up into political arguments in the United States, which I should say not only vaccine hesitancy, but other things such as mask wearing as well there. Which is very unfortunate. Part is due to a great deal of misinformation on the social media there. And as I've mentioned, the US is below 50th in the world with vaccine coverage. As a result of being so low with vaccine coverage, if you compare the change in lifespan in the US to other developed countries, Europe, across the world, you would see that the US has had more deaths from COVID percentage-wise than most countries, and we have lost more years of our lifespan. Our lifespan has dropped about 4 years, for instance, due to COVID, and that is substantially greater than other developed countries across the world, and that equates to lower vaccine coverage and masks being less worn. And that is very unfortunate. About 15 to 20% of the US is absolutely vaccine resistant. That's a very difficult group to deal with. The number who are hesitant, meaning when we first started giving vaccines back in early 2021, has decreased from 50% to only a few percent now, as the vaccines have been demonstrated to be effective and safe, and we've saved hundreds of thousands of lives in the US by vaccine. It is now specifically recommended for pregnant women because there is a higher morbidity and mortality in pregnant women in the United States, and it joins just influenza and pertussis vaccines is in the US is specifically recommended in the for pregnant women. Some of the ways of dealing with vaccine, at least in the US, what you find out is when you talk to patients in the US, why didn't I get a vaccine? Well, when we talk to the physicians, they'll say my patient was worried about the cost of the vaccine, which may not be true elsewhere in the world, worried about how well it worked, worried about the safety. When you talk to patients in the US why they didn't get a vaccine, the number one reason is my physician didn't recommend it strongly to me. So that's one way in the US we need to encourage physicians to strongly recommend this vaccine, as well as other vaccines like mumps, measles, rubella, and varicella. Second, we need to work through local people, people they believe and trust. So in the African American community, for instance, churches, that's also true for some of the Christian evangelicals in the US. That can be a source that they believe. So we need, at least in the US, to work harder at providing vaccines. And worldwide, a separate issue is, of course, many undeveloped countries have not had the same access to vaccines that we've had in the US and China. And we need to do, as a worldwide community, a better job of distributing vaccines to lesser developed countries. Not only is it good for those people there and keeping them ill, it's good for the rest of us that we don't want to see development of new SARS-CoV-2 variants that would escape from vaccines. So we need to make a better effort as a worldwide community to make vaccines available worldwide.
Yeah, thank you, Professor Weber. So is there a question from Patrick?
Yes, question from Patrick for Dr. Rafa Brelik. So how effective is Sinovac vaccine on young children less than 5 years old?
So our data show that at the population level, real-world evidence, effectiveness against severe disease is between 65 to 70%, between 3 to 5 years old. We don't have enough numbers to estimate BE below 3 years so far, so we have to wait to see that. But should be similar to the other groups. I don't see, it's what we've seen all over, during the whole pandemic period. It's been very consistent across all age groups. And against infection is quite low. It's in our experience, it was 35 to 40% with significant confidence intervals. But that is something that we were also expecting to find, considering the way that CoronaVac and other vaccines were performing against infection. Said that, we have a cohort, a community-based cohort that is following 5,000 individuals with PCRs against SARS-CoV-2 every 2 weeks, no matter if subjects have or symptoms or not. That's a collaborative work that we have with the US CDC, and the China CDC is going to add a new one, similar cohort now. And we've seen different things there. It seems that all vaccines will work better for infection when you have this more detailed follow-up. So probably when you analyze at the population level efficacy against infection, it is super biased up to how people behaves and the availability of tests. So I think nowadays we have to focus on severe outcomes when we discuss real-world evidence, and I would consider infection just in the setting of clinical trials or in the setting of cohorts that followed the individuals periodically with PCR or antigen. So I wouldn't. So that's what we found. I wouldn't. That 35%, it's with a lot of uncertainty. And when you follow up the cohort, we do see a decrease in effectiveness at 6 months, but still severe disease is up to 55 or 53%. We haven't published that. We were working on second doses, so we hope to be able to start publishing the follow-up on the kids and the results of the booster in the kids now. So I hope that works.
Thanks so much, brother. May we have 2 follow-up questions? One is with regards to the effectiveness of inactivated vaccine. What would be your prediction that how effective would inactivated vaccine be tackling all those new mutant strains? Now we have more BA.5, BA.4, and then with emerging new strains in the past 1 to 2 months. So we are worrying whether inactivated vaccine will be potential enough to prevent all those severe illness in the future. And also recently, there's starting to have some query from the different community that whether myocarditis. Now we know that there was a small chance of having after mRNA vaccine. It's still also possible that myocarditis may occur after inactivated vaccine.
So the first one, I think it is hard to predict when you consider, if you think about, we still don't have a great surrogate for protection, right? We rely on neutralizing antibodies, but we know that you know, the new lineages of Omicron escape a lot from that. When you see cartographies, you see that you know, Omicron clustered together far away from the response that we were describing for any other lineages. So, and despite that, we see that you know, first generation inactivated vaccines do a great work for preventing severe disease. So I would say that, you know, it would be surprising for CoronaVac and for other vaccines, first generation vaccines, I mean, mRNA vaccines and AstraZeneca, to stop working for severe disease in the near future. I think that's, you know, very improbable. And that's because first, we think that even though infection escapes, you know, the cellular immunity that vaccines elicit are still doing the work. And also because nowadays, I think it's very difficult to rule out the effect of the hybrid immunity. So many people are actually being infected, plus vaccination. So at the end, you try to clean up, and when you study vaccine effectiveness, you try to understand the pure effect of vaccines, but we know that in real life, there are other factors that are protecting the population, and that's, you know, a factor that's hard to measure. So I think first generation vaccines in general are going to continue to be effective for preventing severe outcomes. But at the same time, I think that given all the development of second generation vaccines, we know that mRNA vaccines are already available, and probably CoronaVac is going to have one very soon as well. The natural evolution is going to be start using the new vaccines. So I'm not sure if we're going to be able to answer that question, because probably I might be wrong. Everyone is going to move from first to second generation vaccines that include Omicron. So I don't think we're going to be able to answer that question in the future. That's one thing. And regarding myocarditis, of course, I think we cannot rule out, and we know that the natural infection is associated with myocarditis even more frequently than vaccination with an mRNA vaccine. So using a whole virus might trigger similar responses and had some like a non-infection cause of myocarditis. But as far as I know, there are no red flags regarding that. We have to say that in Chile, we've used massively CoronaVac, but we don't have an active surveillance system for capturing adverse events. So we rely on reporting, and there's always a bias toward under-reporting severe adverse events. So we have to be cautious, and we cannot be sure that it is not something that's going to happen. But so far, as far as I know, there are no red flags regarding myocarditis.
Yeah, I'd like to make just a comment on vaccines in the future. You know, we've seen a shift. Obviously, the initial vaccines were an ancestral strain, and we've been through a whole series of waves. Delta, BA.1.2 Omicron, BA.4.5 Omicron. And it is true that as we've gone through some of these waves, the vaccine effectiveness has dropped off somewhat. But even with those changes over now almost 3 years, the vaccines, the ancestral strain vaccines do remain quite effective against particularly serious outcomes, hospitalizations, and deaths. There are really two issues over time. One, of course, is durability, how long the antibody responses last, and the other is the shifting variants. And it's hard to somewhat disentangle the two there, since really we don't have any ancestral strain COVID around. But both are concerns, and booster vaccines will take care of both of those, meaning particularly as we've now developed the bivalent vaccine, and I'm sure we will see additional Omicron-specific vaccines through other technologies and mRNA as well. So with those booster shots, we will both increase the antibody levels, as we've seen with third and fourth dose. That will help with the durability. And then with a more specific Omicron-specific variants. And we already have had studies, although no one's really used it commercially, of BA.1.2, and they give you tremendous increases in neutralizing antibody specifically. So I think the future is bright for vaccines. They will adapt. We'll be able to adopt them for increased protection across all ages against these new variants. What I can't predict at the current time really is how often and when we will need booster doses. Will the virus be more stabilized with time, and will we only need booster doses very infrequently, or will it ultimately be like influenza, a new vaccine each year, or somewhere in between? I don't think we can really predict that, but I think there's no question that additional vaccine doses with Omicron will improve immunity and decrease serious events.
So another question from the audience. Do you think USA or Europe will provide inactivated vaccine as an alternative option in the future?
I didn't catch quite. Will provide what type of vaccine?
Inactivated vaccine as alternative option.
I think that there's nothing that prevents, obviously, the U.S. Regulatory authorities or European regulatory authorities from looking at any vaccine that a manufacturer wants to bring to the table. Obviously, in the United States, we had approved the J&J vaccine, which was an adenovirus-based vaccine. We've approved the 2 mRNA vaccines made by Pfizer and Moderna. And most recently, we approved the Novavax vaccine, which is a protein-based vaccine, has been approved. So we have 3 separate technologies already approved. And so I think both in Europe and the United States, a company that wants to bring a more classic inactivated vaccine and provide data on safety and efficacy, they would look at the data, and if it showed similar activity to the 3 type of vaccines already approved, I see no reason it would not be approved. But at least in the United States and Europe, it would require a vaccine manufacturer to bring the data to the regulatory authorities and request approval. But based on the fact they've approved 3 separate technologies, I think there would be no prior prejudice against approving a more classically inactivated vaccine, and they would look at the data.
So, Mike, any questions from you?
And I got no more questions. Yeah, thank you.
Okay. So thank you very much. I think it's been a very interesting evening with 2 very excellent lectures and also a lot of very stimulating questions and answers. So for those in the audience who would still want to ask some questions later on, you can email to us. And we thank again the 2 speakers for today. These lectures are really excellent, and we have a recording of them, which we will put out in our website in the future. And this one last question that came up just now, last question for tonight anyway, would be for the 2 speakers, any antiviral drugs for children coming up?
那这个人的立场当然就是说，还是要回到美国主流可是恐怕这个就大概是这样。那我们来看。
Any one last question for the speakers. Any antiviral drugs for children coming up in the market?
So you're talking about antiviral drugs. So, you know, I think obviously, in addition to preventing COVID with vaccines, we would certainly like to have drugs for people who have chosen to be unvaccinated, or as well as those for whom vaccine might not be quite as effective, particularly highly immunocompromised individuals, to treat it. In the United States at the moment, we have 2 oral drugs that are available for treating patients with initial mild to moderate COVID, molnupiravir and Paxlovid, to help prevent progression. And we also have 2 monoclonal antibodies, one called Evusheld that can be used for pre-exposure prophylaxis last 6 months, as one bebtelovimab that's available for intravenous administration, particularly used in immunocompromised people who develop COVID. We use particularly the oral drugs quite widely. The infusion drugs are more difficult to provide. But I will say, as with any other antiviral, that includes drugs for herpes and for varicella zoster and influenza. These are not like antibiotics. Antiviral drugs work best when used early. So you really can't wait and say, well, I just want to see how I do for 4 or 5 days. You need to give them early. And I think these go in partnership with vaccines. In the absence of a vaccine that's essentially 100% effective in preventing illness, developing new and better drugs and therapies will be quite important. The other thing that I think pending in the future are a couple of things. One is our vaccine development colleagues are hard at work at developing a more universal COVID vaccine, so one that we wouldn't need to develop new ones such as a BA.4/5 bivalent variant, but one that would attack a conserved region of the virus. So it would act against all possible variants, and people are working on that. And then the second, at least with mRNA technology that's being worked on, is a combined COVID influenza vaccine, so that if we ever need boosters each year, instead of having to get an influenza boost of a vaccine dose and a COVID booster, they'd all be in the same vaccine. So those are some of the additional technologies that are being looked at. And then, as you know, there are many, many different technologies for making COVID vaccines, everything from live attenuated vaccines to inactivated and many others. And we continue to see work in those areas looking for, again, the goal is always a vaccine that is more effective and safer using a different technology. And I do expect we will continue to see new vaccines being developed as well.
Thank you very much. So lots of exciting things to look forward to in the future. So
and for the audience information in Hong Kong, there's a limitation in the age when using the molnupiravir and also the Paxlovid. So for small children, we can only use the intravenous remdesivir. And unfortunately, all our severe cases, for example, the acute necrotizing viral encephalitis, they all happen in small children. So that is why we have a limitation regarding the antiviral use. So this is, I really want to call to the audience attention. Please kindly advocate the COVID vaccination to our children populations, and also in this season, please also advocate the influenza vaccination for our children. Yeah, thank you.
I do want to just make one quick comment about viruses. We are seeing, and if you look at the Southern Hemisphere, they had a large amount of influenza and other viruses during their winter. And obviously and I do worry that as we get into Northern Hemisphere, we will see an explosion of non-COVID viruses. Just in the last week at my hospital, we had 132 and mostly children with RSV. And we had another 150 isolates of adenovirus, enterovirus, and rhinovirus, at least for being in the Northern Hemisphere. That's and we had about 10 cases of influenza. Very early in the year to be seeing so many other viruses. So I do worry, again, as worldwide we relax masking and lockdowns and other issues, that leaving aside COVID, that this coming winter, and particularly for children, we will see large numbers of children with other viruses. And so I echo the comments that we need to immunize our children against influenza.
Yeah.
We did have a tough winter.
Yeah.
Okay, so thank you very much to our speakers and also to Mike for this exciting evening. And I would also like to thank our sponsors for this evening, Sinovac and Fosun for the BioNTech. And thank you for your sponsorship to make this happen. So we look forward to further discussions maybe later on about the exciting new developments in vaccine and other similar topics. So just a quick reminder for participants, if you'd like to get CME or CNE, there's a QR code you can see on the screen now. So please remember to sign out using the QR code, and then we can book, and then the CME or CNE will be administered. Okay, so it's coming close to 8 o'clock in Hong Kong, and so I must draw the meeting to a close. Thanks again for Professor Dr. Weber and also Dr. Braylick and also Mike for the excellent presentations and discussions. Okay, and then hope to see you again soon in the future.
Thank you very much.
Thank you.
Thank you.
Bye-bye.
Thank you. Thank you. Bye-bye. Thank you.
Bye-bye. Bye-bye. Thank you.